Hi there, I am Suryadharma from Jakarta, Indonesia. This time I will give a lecture about addressing radial artery spasm. I have nothing to disclose. There are several outlines related to this presentation, and we will discuss about the epidemiology, pathophysiology, predictors, and strategies to prevent radial artery spasm. And we also discuss about the role of vasodilators in transradial catheterization, and ended up with several take-home messages. In 2017, we celebrated the 25 years of transradial intervention. Since the first transradial intervention in 1992, there have been a lot of advances in research, clinical, and technical developments in radial approach. And it is expected that transradial intervention will continue to be adopted for endovascular and structural heart procedures, as well as for high-risk and complex PCI. This diagram shows the incidence of radial artery spasm that vary between institutions. In a center with expert transradial operators, we can see here that the incidence of radial artery spasm is very low, 0.8%. And the diagnosis of radial artery spasm can be made by the clinical criteria classified from grade 0 with absence of arm pain to grade 4 with very severe spasm where there is a severe local pain and discomfort associated with catheter trapping. And the definite diagnosis of radial artery spasm can be made based on the radial artery angiogram criteria. As you can see here, this is the baseline where we can see there is no spasm, and after the procedure we can see a severe radial artery spasm and shown by the significant narrowing of the radial artery. And the pathophysiology of radial artery spasm is due to the activation of the predominant alpha-1 adrenoceptors in the radial artery. And these receptors, predominantly the alpha-1 adrenoceptors, are stimulated by the circulating catecholamines and by the mechanical stimuli such as catheter or wire manipulation. And the pain sensation could be due to multiple punctures and anxiety as well. And the radial artery is classified as a type 3 artery with a higher receptor-mediated contractility, hence a higher risk of spasm compared to other arteries. And we have shown that the radial artery is larger than the ulnar artery. There are several predictors of radial artery spasm from this study, show that female small radial artery and diabetes mellitus with multiple puncture attempts are those variables that were associated with radial artery spasm. And the RAS registry showed that multiple puncture attempt is associated with radial artery spasm, as well as the use of large sheath. And the RAS registry also showed that the most common method of treating radial artery spasm is by giving additional medication, in this case, additional vasodilators. And there are several strategies available to treat sheath or catheter entrapment during transradial access, such as the pharmacologic or non-pharmacologic approaches, as well as give deep sedation, or in some cases, we need a surgical intervention. And there are several strategies available to prevent radial artery spasm, such as the use of vasodilators that can be given as an intraarterial injection or topical use or subcutaneous injection, sublingual use, or even we can use topical local anesthetic agent, and also we can use a mild sedation. This study showed that the use of 5 mg verapamil was not associated with a reduced risk of radial artery spasm compared to placebo. However, a meta-analysis showed that the use of 5 mg or 2.5 mg or 1.25 mg of verapamil, either a single dose or in combination, were associated with a reduced risk of radial artery spasm. And from a pooled analysis from almost 9,000 patients showed that the use of 5 mg verapamil or 100 or 200 microgram of nitroglycerin were associated with a reduced risk of radial artery spasm. While the use of topical vasodilator can be seen from the predilate study, which shown that the use of topical mixture of nitroglycerin and lidocaine increases the size of radial artery in patients undergoing transradial catheterization, and this may lead to a reduced risk of radial artery spasm. And we are eagerly await the result from the ongoing study on 300 patients, and they look for the difference in the incidence of radial spasm by giving 40 milligram lidocaine plus 30 milligram of nitroglycerin compared to only 40 milligram lidocaine, with the primary outcome of the incidence of radial artery spasm. And the use of subcutaneous vasodilator can be learned from these relatively small studies, and they have shown that the use of subcutaneous injection of nitroglycerin leads to a significant increase of radial artery diameter, and this avoids the multiple cannulation of the radial artery and may enhance the palpability of the radial pulse and makes the puncture radial artery easier. And this study showed that the use of sublingual nitroglycerin was not different from the use of intra-arterial nitroglycerin in terms of efficiency and safety in the overall study population. And the evidence for the use of topical local anesthetic agent can be seen from this small meta-analysis showed that the use of topical local anesthetic agent was not associated with a reduced risk of radial artery spasm, either in the angiographic criteria or based on the clinical criteria. And the evidence for the use of sedation for radial artery spasm can be seen from the largest study on this treatment, showing that the use of fentanyl and midazolam was associated with a substantial reduction of radial artery spasm compared to placebo, 2.6% versus 8.3%. So now the question is, which vasodilator is the best? So to answer that question, we have to look from this study from almost 2,000 patients, and this study showed that the use of verapamil or nitrates are more effective than diltiazem to prevent radial artery spasm. And also, if we can see here that the use of 2.5 milligram of verapamil could be considered as the first strategy or first choice to prevent radial artery spasm for transradial access. And now, what about, should we use the single or combination of vasodilators to prevent radial artery spasm? So we did this analysis from around 150 patients, a randomized controlled trial, and we have shown that diltiazem plus nitroglycerin showed no advantage compared to nitroglycerin alone for the RAS prevention in transradial approach. And John Coppola and friends have shown that the addition of nitric oxide donor, in this case nitroprusside, to nitroglycerin did not reduce the risk of spasm. So what do the guidelines tell us? The SKY guideline on 2011 recommended the use of 2.5 milligram of verapamil and nitroglycerin. And it is important to dilute the spasmodic cocktail with blood or saline to reduce the burning and artery irritation. So now let's see the real-world experience on the use of spasmodic regimen. The first and second international survey, as well as the International RAS Registry, showed that the most commonly used vasodilators are verapamil and nitroglycerin, and some centers are still using the combination of verapamil plus nitroglycerin. As all we know that verapamil inhibits the calcium ion influx in the vascular smooth muscle cells, while nitroglycerin activates the cyclic TMP. So do experienced radial operators use routine vasodilators as spasmodic regimen to prevent radial artery spasm? And do vasodilators prevent radial artery occlusion after transradial procedure? So if we look at the data from RAS registry showed that actually intra-arterial cocktail did not influence the occurrence of radial artery spasm, and 21% of cases did not use spasmolytic regimen. And the data from international survey on 2010 showed that 14% interventional cardiologists did not use routine spasmolytic regimen. So this was a randomized controlled trial, and we have shown that the use of 500 microgram of nitroglycerin administered through the sheath at the end of the radial procedure was associated with a reduced risk of radial artery occlusion compared to placebo. And we did the post-hoc analysis of that trial and showed that the use of verapamil or nitroglycerin as a spasmolytic regimen that were delivered at the beginning of the procedure was not associated with radial artery occlusion. And this study also showed that severe radial artery spasm was not associated with radial artery occlusion, suggesting that radial artery spasm has no role in the pathophysiology of radial artery occlusion. This randomized controlled trial showed that the use of subcutaneous injection of 500 microgram of nitroglycerin was associated with a reduced risk of radial artery occlusion and may dilate the radial artery compared to placebo. So actually, how to increase the satisfaction of patients undergoing transradial procedure? So we did an analysis to find the predictors of post-procedural arm pain defined as VAS score more than 4 evaluated at a day after the radial procedures. And we found that multiple puncture attempts, hemostasis compression more than 4 hours, small radial artery, and radial artery occlusion were all associated with a VAS score more than 4, thus should be avoided if possible, and special treat should be made in patients with small radial artery. This is a concept to enhance the preservation of the radial artery in transradial catheterization, suggesting that all steps are very important during the transradial catheterization, starting from how we cannulate the radial artery, how to puncture, the selection of sheath and catheter, as well as the procedural characteristic and hemostasis protocols are all should be improved to preserve the radial artery. To summarize this lecture, ladies and gentlemen, that the incidence of moderate to severe radial artery spasm is low in radial centers with experienced radial operators, and the most common method for RAS prevention is the use of intra-arterial vasodilator that was delivered after sheath insertion, and the choices are between nitroglycerin or verapamil. And the use of mild sedation is associated with a reduced risk of radial artery spasm, and the use of a single vasodilator as a spasmolytic regimen is effective. And the benefit of intra-arterial vasodilator is to prevent radial artery spasm as a spasmolytic regimen and to prevent radial artery occlusion if it is delivered at the end of the radial procedure. Thank you.